Hi, thank you for joining me today for my presentation on how to walk away from knee pain with robotic assisted surgery. I wanted to share a little bit about myself before we get into the presentation. I grew up in the San Fernando Valley. I went to Van Nuys High School. I was local for college. I went to UCLA where I studied neuroscience and economics. I then subsequently moved to the Midwest and attended medical school at the Case Western Reserve University in affiliation with the Cleveland Clinic, and then did my orthopedic surgery residency at the University of Chicago. That's where I first started to get exposure to robotic assisted hip replacement surgery. I then was fortunate enough to do my fellowship at the #1 ranked orthopedic hospital in the country, the Hospital for Special Surgery in New York City. It's there that I really refined and learned a lot more of the techniques that I've been able to bring back to my hometown. So I'm very excited and fortunate to be with the Southern California Orthopedic Institute in alliance with UCLA Health. I'm going to be seeing patients in the Thousand Oaks Westlake area, Simi Valley office, as well as the Porter Ranch office. Osteoarthritis. It affects nearly 70 million Americans, or about 1 in every 3 adults. It's the leading cause of disability in the United States. So it's an ongoing issue. It's going to keep getting worse and worse. The Center for Disease Control projects that over 40 million Americans over the age of 65 will have osteoarthritis by the year 2030. So the projections of this are only showing that it's going to become a more and more significant of an issue. Now, knee osteoarthritis is the most common of all arthritic conditions, more common than hip or hand arthritis, which are also fairly common. It is present in about 11% of patients over the age of 65 have some type of symptomatic knee osteoarthritis, to where it's either causing them pain or limiting their activity. And the real interesting thing is it is the highest medical expense of all arthritic conditions. And the reason why this is important is because that basically indicates that Medicare and other payers are going to be looking at ways to manage this in a more effective fashion, because they're spending such significant amounts of money on the management of knee arthritis. So patients ask me this in my clinic all the time. They say, why did this happen to me? What are my risk factors? Well, the most common risk factor is age and genetics, 2 things we really can't change. I always tell patients that they can blame their parents. Females are a little bit higher risk for osteoarthritis just because of hormonal changes that take place throughout their life cycle. High impact activities that may have been from recreation or from occupational requirements can also lead to or accelerate arthritic change. And obesity, which is the most important modifiable risk factor, also contributes to that. And any previous knee injury or trauma is also going to potentially accelerate or create arthritic change. So, the other thing that patients always talk about is, they ask me if they're bone on bone, or how bad is their arthritis. And the reality is that when we get plain x-rays or simple radiographs, it shows us the bones, but it doesn't really do a good job of showing us the meniscus and some of the other structures. And as a knee wears, it's not just the bone that's wearing, it's all the structures around the bone that are wearing as well. So you have wear and tear of the meniscus, you'll see meniscal damage, you'll have some extra bone remodeling that takes place. So, when patients have severe arthritis, they'll ask me, do I have a meniscus tear as well? Well, you likely do, because as the knee degenerates, the meniscus also degenerates in that process. So, when I have patients that see me in clinic, there's some that have normal knees, like the one that you have here. And as the knee wears out, you're going to develop some joint space narrowing, you develop bone spurs, they may have deformity. Either patients may say that they feel like they've become more bow-legged or knock-kneed. And eventually they develop a severely arthritic knee, as you have here all the way on the right. You can see that this knee is completely bone on bone, also is no longer having that same straight alignment. So everybody on this webinar and is somewhere on this spectrum, right? Somewhere between normal and arthritic. And our knees continue to wear out. It's like the tread on the tires of our car. As soon as you start driving that car, you have some wear and tear. So in terms of management options, we've got a few different choices, right? And I always recommend conservative treatment before we even have a conversation about anything surgical. So we talk about non-steroidal anti-inflammatory drugs, Advil or Aleve can be quite effective at reducing some of the inflammation, but long-term use comes with certain challenges and potential issues that can arise. We always talk about weight loss and whatever we can do from that standpoint can help offload the load that our knees see. Bracing tends to be not very effective, but it can be helpful in certain situations. We have a variety of different injections, including cortisone, hyaluronic acid, PRP, stem cells. None of these are really designed to reverse the arthritic condition that the patient has. It's more management of the symptoms that they have. And then as a last resort, we talk about surgical intervention. So when you have a patient with a severely arthritic knee and they failed all conservative treatment, the only option remaining is to do a full knee replacement. And, over time, we've started to realize there's many ways to get from the left side of the screen to the right side of the screen. So before I get into surgical management, I do want to emphasize that this is an elective operation. Everything that I've discussed before, even the injections and medications, they have minimal to no side effects. The risk of complications from those interventions are fairly low. However, once you have surgery, there's no returns after that, and there are certain risks that come with that. And so I always want to make sure that patients have exhausted all conservative treatments before they make the step to proceed with surgery. And I also want to emphasize that we're learning a lot. And I think with the advent and increased use of robotics and other technologies, we're starting to learn a lot more about the things that we don't know. But there's still a lot of things out there that still have a lot more research that needs to be done. So this is an evolving field, and we're going to continue to figure out more things that we don't know and get better and better at addressing some of the anatomic and other variables that each unique specific patient may have. So vast majority of patients who have knee replacement do extremely well, and they're very pleased, and they would likely undergo the operation again. But if you look at registry data, if you look at large studies, the same number, approximately 10%, continues to pop out. And that shows that they demonstrate that about 10% of patients have no radiographic signs of complication. However, they're not happy with their outcome. So this has really been an area that we have focused a lot more on to try to get a better understanding of how do we capture these 10% and why are these 10% of patients perhaps not loving their knee or super happy. So that brings me to what's new and improved in knee replacement. Patients ask me that all the time. Are we doing surgery the same way? My grandmother had knee replacement 30 years ago. Has there been any innovations? And the reality is that, we are doing things the same. The principles haven't changed, but we are doing it differently as well. We've gotten a lot better and a lot more accurate. So one of the things that we know that improper positioning is going to lead to early failure. Just like anything, if it's not put in the correct way, it's going to prematurely fail, as you can see in this X-ray, as well as this cartoon here. So when you have a patient in a situation like this, they have no option but to now undergo a subsequent operation, because obviously it's not feasible for a person to live in this type of alignment. And that is a much bigger operation. It requires a much more invasive surgery. As you can see, that we had to go longer with the implants to compensate for the compromised real estate. And so, the whole goal is to make sure that patients don't need to have a subsequent more extensive operation. So patients ask me this all the time. Why does malalignment occur? Why would anybody intend to put it in incorrectly? And I think the best way for us to understand that is looking at standard knee instrumentation. And I think the best analogy is to think of the Thomas guide. 20, 30 years ago, maybe even more recent than that, I'm sure everybody had a Thomas guide. That's how you would get from point A to point B. And the reality is that now we have so much better technology. You can go into Google, you can go into Waze. It tells you where there's traffic. It tells you where there may be a police officer or an accident, and you can make adjustments of your route accordingly. So that is kind of like what robotics has done for a standard knee replacement. So when you do a standard knee replacement, you have a series of jigs and devices that you use to measure the alignment of the knee and to then subsequently make the cuts in the appropriate position. So you drill a hole in the femur, you insert a rod throughout the entire bone, then you attach these jigs to it where you make certain adjustments based off of the degrees that you want to make the cuts at, based off of measurements that you've made off of x-rays manually. You then execute your cuts that way. On your tibia, you have an extramedullary guide. Basically, this guide clips around a patient's leg, and you try to feel where the ankle is, and you make adjustments in terms of the slope as well as the angle of the cut. Now that you're limited based off of body habitus or other abnormalities in a specific patient's anatomy, which may be present. So the reality is that the problem with standard total knee instrumentation is that's unreliable. And all of these jigs, they can move. And all of these things lead to malalignment, which is what we ultimately do not want to have. And so the final product of a knee replacement with standard knees is a summation of a series of errors. Every single step introduces a level of error, and the final product is just simply a summation of all of those errors. So if you were the patient, how would you feel if the surgeon got it right most of the time? Obviously, you want them to get it perfect every single time, especially when it's your surgery. So I came across this case, and I think it highlights the alignment concept fairly well. There's a 45-year-old female. She was a school teacher. She had bilateral pain isolated to the inside portion of her knees on both sides. And so she was scheduled to undergo a bilateral partial knee replacement. So, I don't advocate for bilateral or simultaneous knee surgery, but in any case, she did have good indications for partial knee replacements based off of her imaging as well as clinical presentation. These are her immediate postoperative radiographs. So you can take a patient who was a perfect candidate for a partial or less invasive knee surgery, and then subsequently had these malpositioned implants that were placed. Anybody looking at these x-rays can agree that the alignment does not appear to be appropriate, nor does the positioning. If you follow this patient over time at 1 month, then 1 year, you can see how the arthritis as well as deformity progresses. And at 3 years, she has substantial deformity. She's unable to walk. She's using a walker. She's 48 years old. She's unable to work. So she's had significant changes and detriment to her quality of life and everything secondary to these malpositioned implants. So you took a patient who had very good indications for a fairly straightforward procedure. She underwent a malaligned partial knee replacement, and now she's got progressive arthritis in the other parts of her knee. So now she's looking at a much larger surgery. So she's now 48 years old and subsequently has already had a revision surgery on both of her knees. And when you come across a case like this, you can't help but think, what should we do to get it right the first time? This is taken out significant years out of her life. And so I think that's where the use of robotics really comes into play. And so I'm really excited to have the opportunity to work with Stryker to bring this technology to the Southern California Orthopedic Institute and offer it to our patients as a way to ensure that they don't end up in that same situation. So I'd like to share a video with you on how the robot works.
One possible treatment option for knee pain is total knee replacement, a procedure that involves removing the damaged bone and cartilage, then replacing the knee joint with an implant to reduce pain and restore the motion and function of the knee. Today, knee replacement surgeries